Kristen, is my volume okay? Can you hear me okay? Okay,
Good.
perfect. Thank you.
Good afternoon. Today is May 15th, 2024, and I will call to order the Green Mountain Care Board's hearing. We have two agenda items today. We have an update from Elena Barabee and Pat Jones on the AHEAD model and the Vermont Medicare Global Payment Design. And then we have a distinguished set of providers and provider representatives who will speak to their perspectives on Vermont's global budget design and the AHEAD model. And I just want to thank everyone in advance for coming and making time to help inform everybody of those very important perspectives. Before we get started, I'll turn to Susan Barrett for the Executive Director's report.
Thank you, Mr. Chair. I have a few public comment periods to announce and then just some scheduling updates. First, we have a new public comment period that we opened today, and that is the board is accepting public comment on the draft OneCare Vermont FY25 budget guidance. And we will be accepting that public comment until noon on Monday, May 20th. We're also accepting public comment on the proposed revisions to the reporting manual for Vermont's all-payer claims database, and that's the Vermont Healthcare Uniform Reporting and Evaluation System, also known as VCURES. And we're accepting those comments through May 31st. We're accepting public comments on an ongoing basis, which I've mentioned before. I'll mention them again. Any comments on the hospital sustainability and community engagement work that we're undertaking per Act 167, those comments are welcomed, as well as comments on the AHEAD model. We're going to hear more from, as Chair Foster said, from our panel today. So that will be really helpful. Thank you again for everyone for coming. And then in terms of scheduling, this evening at 5:30, we have a primary care advisory group meeting, and that is on Teams. So if folks are interested in listening in, please do. And then Monday, this coming Monday, May 20th, we will be conducting a hearing for the Outpatient Surgery Center Certificate of Need for UVM-MC, and that starts at 9 a.m. via Teams. And please just check our schedule. We will keep it updated. It's just a very busy month in May. So with that, I will turn it back to you, Mr. Chair.
Thank you. We have meeting minutes from May 8th, 2024, and I will move for the approval of those minutes.
Second.
All in favor of approval, say aye.
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 Aye. And the minutes are approved unanimously. I'll turn it over to Ms. Barabee, our Director of Health Systems Finance, and to Ms. Jones, the Interim Director of Healthcare Reform at the Agency of Human Services.
Great, thank you. And I believe Michelle's going to be running our slides. Great, thank you, Michelle. Okay, we can skip to the next slide. So we'll cover two topics. I'll take us through a brief update on the Vermont Medicare Hospital Global Payment Design, and then I'll pass the baton over to Director of Healthcare Reform, Pat Jones, who will walk you through an update on the HED model. So we can go to the next slide. So I just wanted to remind folks, I think Susan kind of mentioned our very busy schedule. Some of those dates are on here. So today we'll do that update and talk about the provider panel, but just a reminder, we'll be receiving the draft. So it says near final, but it's still a draft methods paper back to the board based on discussions to date and feedback sometime next week. So probably around the 20th, and then we'll be posting it for public comment. And then walking through that on the 22nd. We'll also hear from an expert panel on value-based care and payment and delivery system reform on that same date. And then, I think we'll have we'll discuss this now, but we'll be thinking about a vote on the methodology or either on the May 29th or June 5th. So Michelle, you can go to the next slide. So just, a summary, this is kind of, we've talked about each of the adjustments and kind of what the required state design methodology is per the agreement. And we walked through a series of adjustments and kind of some ideas for feedback and how that would kind of accumulate to a facility-based payment. And we'll go through those in more detail next time we meet. And Michelle, next slide. But I did want to bring up, so to date, we've been talking about voting on the methods paper. So staff would then submit a specification. So that's really how the kind of the nuts and bolts of how the calculation would work for submission to CMS as part of the negotiations in the HED model. The methodology itself is still kind of part of a broader negotiation, so it doesn't stand alone. But again, the board would vote on the broader model on June 30th. Can we go to the next slide, Michelle? I think there has been some discussion around challenges of voting on a methodology that is kind of contingent on a larger picture and a larger approach and what can be negotiated, given that there's still a lot of outstanding items to kind of design and evaluate. It is difficult for the board to judge the methodology on its own merit, and also because it's part of this broader negotiation. So an alternative that staff had been thinking about would be to vote on a series of principles, and then you would kind of delegate to staff to submit the methodology and then kind of revisit, during negotiations, how this methodology would work with the broader negotiation strategy and what the state can then come to agreement with CMS. So that is something we wanted to propose. So if you want to go to the next slide, Michelle. So we took a stab at coming up with some language and some principles. These principles are based on the feedback and kind of stated objectives of board members. It's also reflecting kind of some of the goals that were reflected in Act 167. Also encompasses some of the goals that were established by the Global Budget Tag Group that has been heavily involved in kind of developing and creating the methods to date for the Medicare piece, at least. And so we wanted to kind of share these with you now, collect your feedback, see if there's any adjustments or additions, take public comment on them, and what other principles we think would be important as the negotiating team kind of moves forward to explore this option. I won't read them to you, but I think a lot of these kind of echo a lot of similar principles just in advancing the work of the board. We care about kind of controlling costs, controlling healthcare cost growth, making sure we're working towards more affordable, high quality care, that the methodology is transparent and data driven, that we're working towards an all-payer approach, so we're not further bifurcating and creating kind of different systems. We want to kind of work towards a single simplified system, if you will, and that whatever payment reform efforts kind of contribute to improving access and high-quality care for Vermonters. So you can go to the next slide. And so, we can take your comments either today or over the next week or so, but I imagine you'll probably want to think about this since we're just proposing it for the first time, but we'd love to hear your thoughts on voting on a Medicare hospital global payment. Do you want to vote on the final product or, delegate these and establish these principles? And then do you have, if the latter, do you have thoughts on the list of principles that we've proposed here? And any additions. And again, we'll revisit this topic on May 22nd when we review the updated draft methods paper. And I think that's all I have before we pass it over to Pat. So I'll pause if there are any questions, Chair Foster, if you'd like to wait till the end.
If board members have any questions or comments, now's fine. I have none, and I thank you for that quick overview.
Okay, so I will pass it over to Pat. Thank you very much.
Good afternoon, everyone. Thank you for once again having me back to provide an update on the AHEAD model. Next slide, Michelle. So when in talking with Green Mountain Care Board staff, 3 areas were highlighted that might be helpful today. The first is to provide a bit more detail on timelines for the AHEAD model. The second was to describe potential areas for negotiation. And then the third was to spend some time talking about system transformation and how we might prepare our healthcare system for care delivery transformation. So I'll be spending actually most of my time on that topic. So next slide. So this is sort of the highest level timeline to get us started, but then I'll do a deeper dive. So Vermont, just as a refresher, Vermont has applied as a cohort 1 state for the AHEAD model. So the applications were due on March 18th of this year. We actually submitted ours on March 15th. And worked really closely with the board staff and really appreciated the work there. We are now hearing that CMMI will select states in June of 2024. They had talked about late May or June. It looks like it is going to be June of 2024. So that's when we expect to hear whether or not Vermont has been selected. After that, there's a 18-month pre-implementation period extending from July 1st to December 31st of 2025. And that's actually a very busy time. And you'll see it both in the more detailed timelines and also when we talk about some of the areas for negotiation. But that pre-implementation period takes us right up until the end of 2025. And then the first performance year for cohort 1 states is begins on January 1st of 2026. It's up to a 9-year model. So the idea is that it would extend through 2034. Next slide. So these next 2 slides where we really try to describe the key model milestones, this is information that we've gleaned mostly from the notice of funding opportunity that CMMI put out a few months ago. And so this first slide talks about what happens during that pre-implementation period for the cohort 1 states. So if the performance year starts on January 1st of 2026 and you take, an 18-month look back, So July of 2024, there are some really key milestones there. And one of them, this board has been talking about quite a bit in recent meetings. And that is that by July 1st, if states are doing a state-designed Medicare fee-for-service hospital global budget methodology, it needs to be submitted to CMS. So that's been really a large focus of the board's work and of our work together, is developing that methodology. In addition, Medicaid needs to share a proposal for a primary care alternative payment model and for the regulatory pathway or processes that Medicaid would propose for a Medicaid hospital global budget. So a couple comments there. Medicaid, we've talked about this before, but Medicaid's in pretty good shape in terms of that primary care alternative payment model. The priorities and principles that CMS has outlined for the primary care model looks an awful lot like the blueprint for health. So we feel like that's a place where we're in good shape. And then we've also, been contemplating, we have an 1115 waiver and some other mechanisms that could serve as regulatory pathways for the Medicaid hospital global budget. So, but both of those things are also due in July of 2024. The next, significant milestone that we've been able to glean from the NOFO is that within 6 months after an award is given to a state, so a state is selected for the AHEAD model, states would need to establish the model governance structure. And you all may recall that that's a very representative, broad-based group of a variety of stakeholders with a lot of that group's work is focused on health equity. So that needs to be in place within 6 months. So if awards are made in June, think, November, December is when we'd want to have that model governance structure set up. Then 12 months prior to the start of the first performance year, so in January of 2025, that's when Medicaid would need to submit its hospital global budget methodology to CMS. And, following the alignment principles that have been set forth in the notice of funding opportunity. 6 months prior to the start of that performance year, so in July of 2025, and this is, undoubtedly our most significant milestone during the pre-implementation period. That is when the state level agreement with CMS needs to be executed. So, all during this time, from the time of selection and award of the cooperative agreement funding and so forth, negotiations would begin between those states that have been selected and CMS. And until that agreement is executed, Vermont or any other state that might be selected has not committed to participating in AHEAD until that agreement is signed. Also, in July of 2025, we would be looking for letters of interest from hospitals that want to participate in the Medicare fee-for-service hospital global budgets. We'd be expecting to see CMS approval of that Medicaid hospital global budget methodology. And you may recall that for some of the statewide accountabilities, most notably total cost of care and primary care investment or spending, the all-payer targets have to be codified. And so by October of 2025, we have to have a final either executive order, and that's what the governor's office has indicated, or it could be rule or legislation. But it's not the targets per se that have to be in place by October, but the process of setting those all-payer total cost of care and primary care investment targets would need to be established. So we're thinking drafting, having a draft in July of 2025 at the latest, and then finalizing by October of 2025. That's required in the NOFO. Other things that would need to occur by October of 2025, demonstrating that there's readiness for Medicaid hospital global budget implementation and Medicaid primary care alternative payment model. Again, we already have a Medicaid primary care alternative payment model in place, but some states don't. And so the requirement is that readiness be demonstrated by October of 2025. That's also when CMS would want to verify that at least 10% of Medicare fee-for-service net patient revenue will be under the Medicare hospital global budgets, as reflected in the hospitals that have agreed to participate in Medicare hospital global budgets. So that's a requirement in order for the model to get underway, is that 10% in that first performance year would have to be under hospital global budgets. And then at the end of that pre-implementation period, so December of 2025, a statewide health equity plan would need to be finalized. And that again is a key part of the work of that model governance structure. So as I mentioned before, pretty busy time for states that get selected in that pre-implementation period. Next slide. So this slide talks about what happens after that, performance year 1, 2, 3, and beyond. So for performance year 1, at the beginning of that year, January of 2026, we would need to be prepared that Medicare primary care ahead would be implemented, and that the Medicaid primary care alternative payment model would also go live. And again, the blueprint would serve as our alternative payment model. There would also need to be implementation, that would start January of 2026, would begin the implementation of Medicare hospital global budgets. 90 days before the start of the second performance year, so in October of 2026, that's when those final all-payer statewide total cost of care and primary care investment targets would need to be finalized, and they would be included in an amended state agreement between states and CMS. So that's another key milestone. So the process established during 2025, the targets themselves identified and memorialized in those amended agreements. And then also by October of 2026, that's when we would need to have at least one commercial payer indicating that they will participate in a hospital global budget model. And then by the end of that performance year, by December of 2026, that's when Medicaid hospital global budgets would need to be implemented. So a little later time frame, potentially for Medicaid hospital global budgets. Could happen sooner as well. So that's performance year 1. Performance year 2, at the beginning, that's when measurement against those all-payer total cost of care and primary care investment targets would begin. And again, those are at the statewide level. There would be that expectation that the Medicaid hospital global budgets would then go live, and that we would have at least one commercial payer in a hospital global budget as well. And then we've been talking, CMS has been indicating that they will look toward a capitated track for their primary care ahead program. They're not prepared to do that in the first performance year 2026. They have said that they plan to offer a prospective payment capitated track, like some of our practices here in Vermont have been able to participate in under our all payer model. So they will look to develop that model. So they've said potentially for 2027. So that's something we'll really want to keep an eye on, as well as an option for primary care if we get selected and if we decide to move forward. And then performance year 3 and beyond. So there's another milestone in terms of the amount of Medicare fee-for-service net patient revenue for hospitals is under the global budget. That benchmark is 30%. So we would expect CMS to be verifying by October of 2028 that there is at least 30% of that net patient revenue in global budgets. So that's that's a more detailed look at sort of milestones and time frames. It's again, we've gleaned a lot of that from the notice of funding opportunity, from webinars and conversations with CMS, their materials, but that's sort of the lay of the land over the next couple to few years in this model. Next slide. So, in terms of that state level agreement that needs to be executed by July of 2025, as I mentioned, negotiations will really start by when states are selected. And as we look at the notice of funding opportunity and look at the requirements of the AHEAD model, we think that there are quite a few areas where there can be discussions and potentially negotiations with CMS during that pre-implementation period in advance of the signing of the state level agreement. So we've bucketed them, and this is sort of a dynamic list, and I want to be clear about that, but we've identified several buckets where we think that there's some potential for negotiation. Statewide accountability, hospital global budgets, primary care ahead, Medicare waivers, and then technical assistance. And so within those categories, we've identified the topics, together, AHS and Green Mountain Care Board staff and our contractors. We've identified some areas some topics where we think there is some room for negotiation. And then estimated timing. So when you see early, medium, later, early is in 2024. We want to be really digging in on these topics. Medium, think early 2025, and later, not all that late, but later in 2025. So I'll just outline some of the topics that we think could benefit from further discussion. The first, not surprisingly, is the Medicare total cost of care targets. And then secondly, that's an earlier discussion. That's something we would want to really dig into pretty quickly. And then later, but not too much later, the all-payer total cost of care targets. And, again, that's something that CMS is really looking to the states to, identify and work on, but it's a potential area of negotiation and discussion. Similarly, the Medicare primary care investment targets, we see that as an earlier discussion. And then the all-payer primary care investment targets, we think would be a later discussion topic. As you know, in an additional statewide accountability is the population health and equity targets, and we see that as something that we'd want to really make sure we're digging into early in 2025. So that's the statewide accountabilities. In terms of the hospital global budgets, again, you all have really been digging into the Vermont-specific Medicare fee-for-service hospital global budget methodology. That work has been ongoing through our hospital global budget technical advisory group. It's been ongoing as part of the board's discussions. And so clearly a very early topic, especially since that methodology has to be submitted by July 1st. And then similarly, on a slightly less compressed time frame, is the Medicaid hospital global budget methodology. CMS has outlined principles for alignment, but we believe there's some room for discussion there. And then assuming, that we move forward, this is a very Vermont specific thing, but we do have the opportunity to have Medicare continue to support their portion of blueprint payments, and then also the support and services at home, or SASH program, which is almost wholly funded by Medicare. And how those payments are treated and the mechanics of those payments is going to be important. And so we see that as an early discussion too, should we be selected for the model. Primary care ahead, there's a number of areas there where we think that there's some important discussions to be had. I mentioned already that CMS has indicated an openness to primary care capitation. And so we would want to really, because we have really some relevant and good experience with capitated payment models for primary care, we'd want to be part of that discussion. We don't know when CMS will open that up and start talking about that, but we want to be there when that happens. Quality measures for primary care, they've outlined some proposed quality measures. They tend to be measures that we're familiar with, but we'll want to look and see if there's some choices to be made there from their list. And they've indicated that there's some potential to propose other measures if states desire. So we'll want to make sure that we engage in that. And then for measures that rely on clinical data, medical record data, They look like they'll be requiring them to use the electronic clinical quality measure reporting mechanism. Our understanding is that most of our states have certified most of our primary care practices have certified electronic health records and the capability to do that, but it's something we're going to really want to pay attention to in case practices that want to participate don't have that capability. So that seems like an early to medium discussion. Merit-based incentive payments reporting. Under our current all-payer model, primary care practices are exempt from having to report through that system, and they get automatic payments for that, for those measures, because our all-payer model is considered to be what's called an advanced alternative payment model. So by virtue of that, it exempts practices from that reporting. We are exploring some potential pathways to trying to maintain that exemption, because what CMS has indicated is that until they move to a capitation type model, which would be more advanced, they don't see primary care ahead, which is really based on fee for service with an additional enhanced primary care payment as meeting those requirements for exemption. But we think there may be, we've had some conversations and we think there might be some other mechanisms. So that's very much an ongoing and early discussion. How the Medicare primary care payment model under AHEAD would interface with the requirement for increased investment in primary care is something that's a bit unclear. And so we feel like that's something that could use discussion, clarification, and is an early discussion. And then how primary care payments are risk adjusted. That's another thing that we think is an early discussion. All of these really, getting answers to some of these elements as soon as possible is important in terms of primary care practices understanding what the model means and what the value may be to them. So we consider all of these really early type discussions. Medicare waivers, this is where Medicare actually waives regulations to support goals of alternative payment models and to improve care delivery. We have some of those waivers in our current all-payer model. There's an openness to extending some of those options if we extend the model into 2025. And it can really, there can be some creative care delivery that happens with these waiving of regulations. And so that's a conversation that's been ongoing, and we'd want to continue that in the fairly near term. And then technical assistance for the state and for providers. I'll just give an example. One of the questions that's come up is, there's some models that that providers can participate in at the same time as AHEAD. So one example is the Medicare Shared Savings Programs. And so, the question really is, how do those interface and what does it mean if they participate in both? So we'd like to have some of those answers sooner rather than later as well. So I want to again emphasize this is very much a dynamic document. Obviously the strategy is, executive session type discussion, but these are some of the areas where we think there's some opportunity for discussion. Chair Foster, looks like your hand is up.
One quick question. With Maryland and Pennsylvania, did they qualify as advanced alternative payment models?
I'm not sure about Pennsylvania. I actually think that Maryland has some different tracks in their primary care program, and we're actually planning to talk with them to learn more about that because we think that they might have some learnings that they could share with us about that. I'm not
Thank you.
as sure about Pennsylvania, but I do know that Maryland has at least some tracks that would qualify. Okay. All right, next slide. So at this point, I'd like to sort of dig into, and this is obviously a huge topic, but how can we, support the healthcare system, and I mean really the broader health and human services system, because we're, all of the components of our care delivery in Vermont play a role in the success or not of models like this. So, really want to spend some time talking about what are people envisioning, what are, on the Medicaid side, Medicare, and also to the point that was made earlier by Director Barabay about a key principle being multi-payer approaches. How are different payers and providers thinking about care transformation? So, this is really just going to scratch the surface. But what I hope that you'll take away from this is that, we're all certainly providers, certainly people at AHS, at the Green Mountain Care Board. We're all thinking about how we can support care transformation in a way that leads to a sustainable healthcare system, and that most importantly improves health and outcomes for Vermonters. So, huge topic. I'll scratch the surface here, but I hope it's somewhat helpful to the discussion. Next slide. So, in the healthcare reform arena, which we're all in, it certainly isn't limited to AHS and my office, but when we think about what we've been focused on in recent years, or really, it can be boiled down to two big areas. One is the stability of our healthcare system, and that, there were certainly challenges before the pandemic. They seem to have been exacerbated by the pandemic and after the pandemic. So, one key area is how can we, in the short term and in the longer term, how can we stabilize our healthcare system? And I know you all think about that as you do your regulatory and other work as well. Second, what's our vision and direction? How can we know that one reform isn't going to solve all of the healthcare problems, but how can we really have a strong focus on aligned and comprehensive reforms that really do address the challenges that we're facing, and how can we prepare for a potential future multi-payer model like AHEAD or other models? So when we think about the work we're doing, it tends to fall into one of those two areas. Next slide. So I've talked about this with you all before, so I won't, belabor it, but we really, in the Medicaid program here in Vermont, we really have had quite a focus on stability in recent years and on the broader system of care. So we've committed, with the help of the legislature and the governor, over $164 million in base rate increases across the health system over the last 2 fiscal years and across the provider continuum. We have made targeted investments in areas where we see need in the past 3 to 4 years. And some of those examples include the 988 Suicide Prevention Lifeline, Mental Health Mobile Crisis, and Youth Inpatient and Residential Mental Health Treatment as well. The blueprint, and I'm going to actually use this as an example in a couple minutes, but we have sought and received appropriations to expand mental health services, substance use disorder services, screening for health-related social needs in primary care practices that participate in the blueprint. So really key area. Skilled nursing beds. There have been, there are people with complex needs who need a different type of and different level of skilled nursing facility. And so we're working on standing up a facility for folks with complex needs that should be in place later this year. And then for another sector of the healthcare system, home health, we sought and received provider tax relief for home health agencies. So those are some of the examples. Workforce is another area that we've been involved in. And so there has been funding and a number of initiatives to really partner with healthcare and home and community-based service providers on recruiting, retaining, and growing the nursing workforce, other types of workers. And we also are in the process of setting up a healthcare workforce data center. And that should really provide some key information on what's happening. It really pulls information that's out there together and additional information to let us know what's happening in the healthcare workforce. And then we were able to take advantage of an enhanced federal match for home and community-based services. And among other things, those funds have been used to establish a grant program for HCBS providers to allow them to address infrastructure, workforce, care model innovation, and strengthening provider processes. So, that's just tip of the iceberg, but a number of efforts going on to improve stability in the broader system of care. Next slide. This is a slide, we tend to call it our portfolio slide, and haven't shown this in a while, but it really lays out, moving on from stability and looking at what's really the vision for a statewide approach for healthcare reform. This captures sort of the different layers that we have used to try and support providers, provide incentives for improvement, and really try to meet some of those key goals for healthcare reform. So that the top layer really talks about what are the statewide accountabilities or statewide targets that we can, really reinforce to help improve efficiency, to help improve quality, access. And so you'll see some of those elements. Total cost of care is one. and that speaks to affordability and to efficiency. Quality speaks to better health and outcomes. What I haven't added here, but really should, is the primary care investment statewide accountability that is part of the AHEAD model, and health equity. So what are some of those key targets that we can agree on that really help us all drive toward the same results and outcomes? And then that intermediate level is a way of, the broader targets are great because they sort of serve as a North Star, but then how can we start to tailor payments and other supports to providers to help reinforce achievement of those broader goals? So an example of that intermediate layer is what we call shared quality payments. And those are measures where how two or more providers work together can really make a difference in outcomes for patients. And so a couple of examples. One is follow-up after hospitalization for mental illness. Clearly, that includes both the hospital and outpatient service providers. Readmissions are another one that's an example of, where if you can reinforce and actually provide payment for successful results on those measures, it really encourages providers to work together. And we've done, we've got a lot of those measures in some of our current programs. And then that more direct layer at the bottom of the graphic really talks about, specific provider supports, using payments that encourage, optimal care, high quality care. These could be multi-payer payments. They can be payer specific. A lot of the work we've done is Medicaid specific, but there's also some really notable multi-payer work as well. So examples there for the different provider types: blueprints, patient-centered medical home payments, and community health team payments. Those are multi-payer in Vermont. Enhanced and population-based payments. The AHEAD model talks about an enhanced primary care payment. Our current model uses population-based payments. So that's another example. Health system global budgets, which the AHEAD model is looking toward, that's an example as well. Case rates. We have Medicaid case rates for mental health. Adult and children's mental health rate right now. So that's another example. And then episodic payments as well. So an example there is that we've implemented episodic payments for residential substance use disorder treatment. So some of those even more direct payments and supports that provide flexibility can help us achieve those broader goals. So that's, it's a bit of a busy graphic, but it really does sort of lay out that it takes all of those things, the statewide accountabilities and focus, which really gets us driving in the same direction. The shared quality payments when there's multiple providers that work together to support a person's needs, and then those more provider-specific payments that can help us support delivery of services. So, next slide, please. I'm going to pick it up a little here because I know we're getting short on time, but I did want to, just use the blueprint as one example. We started out with that program with patient-centered medical homes and community health teams, but as other needs became apparent, opioid use disorder, and working with the health department to stand up the hub and spoke program through the Blueprint community health teams. the Pregnancy Intention Initiative, which, provides care for people of childbearing age, and also really digs into social determinants of health and psychosocial screening. That's another more specialized program that was set up through the Blueprint. And then the SASH program actually started when Medicare started funding the Blueprint program, and that was focused on serving, providing wellness nurses and care coordinators to work with elderly and disabled Medicare beneficiaries. So those are examples of how a program can evolve as needs of the population evolves. Next slide. And then most recently, we are in the second year now, or about to be in the second year, I guess, of the 2-year pilot for the Blueprint for Health to improve access to mental health, substance use disorder services, and address social determinants of health in primary care. So integrating services with primary care. And that's just one example. All those other programs, the skilled nursing facility beds for people with complex needs, several mental health initiatives, all of those, are really intended to identify and address needs and to prepare the system and support the system in care delivery transformation. Next slide. So federally, and I'm going to actually move through these quite quickly because you've seen some of these slides before, but while Medicare models don't always have specific investments for the broader system of care, because they don't always fund those services. What we do see in the federal models is that they encourage organizations to partner together to meet broader needs for folks. They highlight the potential that if there are savings and efficiencies to shift funding to preventive and community-based care. A lot of that flexibility that you see in their models does support that shifting of resources. The Medicare waivers I talked about already. And then CMS is very focused on advancing multi-payer approaches, as you all had mentioned earlier as being important. Next slide. So in the AHEAD model, they specifically speak to transforming care. As it says here, they aim to support hospitals in transforming care delivery and shifting utilization to primary care and community-based settings where appropriate. And then in primary care AHEAD, they want to see alignment with state Medicaid primary care goals, but they very much are focused on having Medicare join that effort through increased investment and through supporting care transformation initiatives. Next slide. So in terms of hospital global budgets, this slide really outlines where they see that global budgets could support cost control, quality, and also care delivery transformation. So steady, predictable financing, flexibility in how to provide services, supports for improving equity and quality of care and the health of the whole population, ability under global budgets for hospitals to share in savings when avoidable services, use of services can be reduced. And then they are providing funding, and this could be, a point of negotiation, but they are adding funding in the early years of hospital global budgets to support transformation, controlling growth in hospital spending, and then opportunities to learn from other hospitals that have joined the model. The fact that states can help design that hospital global budget methodology for Medicare and also for Medicaid and commercial, it really does, potentially offer an opportunity to address some of our transformation goals. Next slide. You've seen this before, but this is, this is their slide. This is CMS's slide. The boxes are ours, but the circles are theirs. And, they've talked about what they want to see when they provide enhanced payments to primary care. They want to see integration of mental health and substance use disorder treatment in primary care. They want to see efforts to identify and address health-related social needs, and then improving coordination of care and, particularly specialty care. And these are just, the boxes are just some examples. But this, again, is what we've been working on here in Vermont together with our, community providers. This is what we've been working on with the blueprint. So it feels very supportive of the efforts that we've been engaging in here. Next slide. And you've seen this before too, so I won't dwell on it, but it outlines some of the waiver flexibilities that we think if we move forward with a 2025 extension of the current model, CMS has indicated that they will add these waiver flexibilities. And again, that can really help support care delivery and care transformation. Next slide. Health equity, very key to the AHEAD model. And in particular, states that are selected will be expected to develop a statewide health equity plan. Hospitals that participate in global budgets will be required to have hospital equity plans. Support for enhancing data collection on demographics so that we can actually monitor disparities of health and what the impacts are of initiatives. And then again, similar to what was mentioned in the primary care transformation, screening and referrals for health-related social needs. All of these are intended to be part of the model and are supportive of care transformation. Next slide. And then also in AHEAD, there's a quality strategy as well. And it's at really 3 different levels. Statewide, what are the statewide quality accountabilities with a health equity focus, primary care, and then hospital quality programs as well, many of which are already in place, but really looking to assess how care delivery is going and how transformation is being implemented. And then I think my last slide is, just a summary, and you've heard me say this before, but how the AHEAD model really fits in the context of broader healthcare reform. If we were to move forward with it, it would be one component. It could, potentially address some of our challenges. It ensures that we have that multi-payer approach where Medicare can join Medicaid and commercial insurers in paying for health care differently. It does have an emphasis on primary care and hospital payments, and a requirement for care transformation activities, health equity central to the model. In Vermont, it would continue support for the blueprint and SASH. The waivers, we've talked about how they could provide flexibility. And then finally, those statewide accountabilities related to total cost of care, primary care, equity, and population health outcomes. And that's it. Thank you again for having the chance to come and talk to you about where we're at.
Thank you very much, Ms. Jones. Why don't we do board member questions and then we'll turn to the provider panel if there are any board comments or questions for Ms. Jones or Ms. Barabee. I had one brief one on slide 17 and the $164 million in base rate increases. I was wondering if you could speak to that a little bit more specifically in terms of the kinds of investments and what they were used for. I think that might be helpful.
Yeah, they tend to be rate increases for various provider types. And I can, I can get more detail for you and bring it back. But it could include everything from, we made some rate increases in some of the choices for care programs, for example, adult day services. There were we brought primary care payments up to, I believe it's 110% of Medicare rates. So, we're always looking at what our rates are for the various provider types. And, we do rate studies at times and really assess how those rates are really keeping up, honestly. And I'm happy to I can provide you actually with a listing of that would give you more specifics.
Yeah, that'd be helpful. I'd love to see that. So thank you.
Sure.
I have nothing else. Okay.
I guess the one thing that I would ask, Pat, and thanks so much again for coming, is I think I'd love to learn more at some point about the Medicaid global budget methodology for us to think about the Medicare and commercial components and how they interact. If that's something at some point we could get an update on. And also, I think all the hard work that the state and AHS has done to try to alleviate the post-acute care bottlenecks that hospitals have been experiencing with trying to discharge patients and support for long-term care. So those are two things that I'd love to hear more about the hard work you're doing.
Great, thank you. I will share that. And in terms of the Medicaid global budget methodology, I'll just say we're not, well, in some ways, we are farther along because of, the experience with the current model. And there's some elements of that could lend themselves to design of a Medicaid global budget methodology. But I'll also say because of the different timing, we're not as far along on that as the Medicare methodology. But I know that we would be glad to share where we're at on that and what our plans are with that. So thanks for asking.
Thanks.
Okay, thank you very much, Ms. Jones.
Thank you.
I'll turn to our next discussion, which is a provider perspective on Vermont's global budget design. We have a number of providers and industry groups that are here to speak to us. I will quickly go through the list so people have a general sense of who everyone is. And if it works for the panel, I'll have you go in the order that you're on the agenda. If that doesn't work for you, that's fine, but it might be the most organized way, unless you've agreed to do something different. But I'll go through it quickly. We have Alicia Jacobs from the Vermont Academy of Family Physicians, Rick Dooley from Health First, Susan Ridson from Health First, Jessa Barnard from the Vermont Medical Society, Andrew Garland from Blue Cross Blue Shield Vermont, Mary Kate Molman from Bi-State, Judy Fox from Rutland Regional Medical Center, John Aislinn from Primary Care Health Partners, Joe Wooden from Copley, Rick Vincent from UVM, Devin Green from the Vermont Association of Hospitals and Health Systems, Trey Dobson from Southwestern Vermont Medical Center, and Mike Fisher from the Healthcare Advocate. So I'll turn it over to Alicia Jacobs, if you're ready.
Now, can you hear me okay? Sorry, I was going the wrong place. Thank you very much. Good afternoon, everyone. I am Alicia Jacobs. I am a family medicine physician. I have been in Vermont since '96. I came here for residency, worked at the Community Health Center for a couple of years, and have been hospital employed at the Colchester practice of the UVM Health Network for over 20 years now. I am coming, though I also for the past 5 years have been on the board of the Vermont chapter of the American Academy of Family Physicians. I function as a delegate for the state of Vermont at the national level, and I also sit on a commission of the AAFP on quality and practice. And we discussed things like payment reform. And so I advocated at a national level on these issues. So you know, I have other roles too. So in full disclosure, I was the vice chair of clinical operations in the Department of Family Medicine for 12 years. So I have a lot of operational experience. I have moved from that into a well-being informaticist role. I really believe in supporting the healthcare workforce through all means possible. And now I'm trying to do so through digital health. And lastly, I do have a role at OneCare as well. I work particularly in the comprehensive payment reform, some work around the SNF, the skilled nursing facilities that we're trying to problem solve statewide. I also am the chair of the Health Equity and Access Work Group, and I've been participating in our statewide initiative to get standardized in how we screen and respond to the health needs assessments that we do. So I would tell you all of these probably contribute to my opinions, but I'm really coming as an advocate from the Academy, the chapter. You all, I think you're the choir. I don't think I need to convince you that primary care is high value, but I want to say it out loud. I don't want to be too vitriolic, but I kind of believe that family medicine could save the world if everybody just had a family medicine doc to take care of them and allow them to at least have enough health to live, a good life. So I'm coming from that perspective, and I also can tell you, I've managed the family medicine workforce, and I'm connected to lots of people in different ways throughout the state. And the level of burnout in family medicine, in primary care, I should say, is really exponentially high, reaching up into the 80% sometimes. So I'm concerned about our workforce. I will tell you, I feel a little less concerned after hearing that presentation. I do want to say thank you because it was really helpful, and I appreciate that we have, I do hear and I appreciate that we have like the right goals in mind, and yet I still have some concerns. I would, and I do want to do a shout out for the efforts the state has been doing in reducing administrative burden because there are things like that will really change our lives. The prior auths and the telehealth parity, that is really important to us. What I'm particularly worried about is this fragile workforce and this major disruptive change that's coming. So I would like to, if I can, for just 1 minute, talk about what I love about the all-payer model. And you shouted out some of them. I love the waivers. I love the all state, like we are all part of this and it is novel. When I go and present nationally on some of the work we're doing, people are watching us. This is, and they are saying, when are you, like, they are watching Vermont. And so it's really important that we do this work together. I love that we collaborate across organizations. I love it that I'm in the room with independent practitioners working on quality work. I love that we have capitated payments and stability. And I also love, like really love, sorry, I'm being a lot, our comprehensive payment reform, which has been a really novel way to grow the investment in primary care. Any other states that have been doing that are doing it through legislation or executive order. We're doing it through the ACO. And I think it's been like a fantastic model that has stabilized a lot of independent practices, particularly was wonderful during the pandemic, but we've also been able to grow it over time. And we still have a 5-year plan for how to develop that further. So that's a list of the things I love about what things are like now. Here are my concerns about ahead. I actually am worried that it's actually going to be an overall decrease in primary care investment. I understand that the PMPM will be going up, but I'm concerned that if it's not all payers, that it's going to just be a small segment of our patient populations, and hence the actual investment will go down overall. I'm also concerned about the cognitive overload of having different systems for different payers, and that's not what we have now. So that feels like a lot to me, and I'm worried about that. I'm worried that it's Medicare only and Medicare Advantage gets exempted. I don't like that. I'll just say that out loud. And that's along those lines of, I want to treat all my patients all the same. That's how we're going to get health equity, right? And so I don't want to have different systems for different populations. I am worried that it's going to be a big loss for primary care. We have made great gains in transformation towards value-based care. I can speak as an employee of the UVM Health Network. We have a massive high-value care transformation going on right now. I'm not really worried that that's going to come apart, but I do worry that our comprehensive payment reform will come apart, and I'm very concerned about my colleagues that are in independent practices. I don't want increased reporting. I'm very concerned about the MIP, so I appreciate you trying to negotiate that, an exemption to that. And I'm also concerned that certain hospitals can opt out. Again, there's something really powerful about our all-payer model where everyone participates. And I would be in favor of trying to negotiate something where that continues. And then there's the whole change control and who would manage this, and how are we going to support our fragile workforce during this massive change? And that is like just a large question also. So just in summary, I'm not worried about me. I'm going to be fine, but I am worried about our group of primary care physicians. I watch time after time, I watch them like decrease their FTE, do less and less because it's harder and harder to do this work. And I'm worried that we're contracting our workforce and we're not supporting them enough. And that hence I'm worried about like the health of all our Vermonters. So if I have a quick like list of recommendations, I love that you're exploring all options. That I kind of understand this is really our only option, and but maybe there are other options. I just exploring all options and all strategies to make this work for us. I appreciate that. I want to say I really would implore us to look for an exemption to the MIPS requirement, to continue those waivers, and somehow work on all hospital and all payer participation. And then just don't drop our primary care workforce. And I don't know what that means for both the transition and when we start but really making sure that we're using novel ways to increase our investment in primary care. Thank you very much for listening.
Thank you very much, Alicia. Rick Dooley?
Hi, thank you so much. I appreciate Alicia's comments. I think she actually read right off my notes because I think I have every single point that she had. So I'd like to just say ditto, but I'm going to highlight a few things. I'll do it quickly though. So my name's Rick Dooley. I work for Thomas Chitton Health Center. I'm a family practice PA there and have been for the last 24 years or so. I'm also the clinical network director for Health First, representing independent practices across the state. I also came here in 1996 as well and have been doing primary care ever since. So I think we've all heard a lot about the AHEAD model, and Pat, I really appreciate your overview today. A lot of my concerns, you did address some of them today as well. So I think the strengths that I hear from most of my independent colleagues about the AHEAD model is certainly anything that increases funding to primary care is fantastic. Anything that gives us more money to provide that care is great. We're underfunded as it is. I think the fact that this would allow us to continue with Blueprint and SASH funding, retain some of those waivers, especially like the 3-day skilled nursing facility waiver, fantastic. The alignment of the behavioral health integration, the health-related social needs screening, and the care coordination goals in the transformation model, that's great. It's work we're already doing, so we appreciate that. That being said, there are definitely some significant concerns. The provider community has provided feedback straight through this whole process, both in the AHS primary care work group and the Green Mountain Care Board primary care advisory group. So I know these are not things that are going to be new to most people on this call, because the same concerns have consistently risen to the top of the list. There's a crippling lack of access to primary care. We need more support for primary care to reduce administrative burden and an increased ability to recruit and retain providers. And we also need more flexibility in how care is delivered so that we can support and reimburse use of other providers, since we clearly don't have enough NPs, PAs, and physicians to do the work. It's not clear to many in the provider community how the AHEAD model actually addresses those access concerns or how it will encourage people to come into primary care. We share the same concerns that Alicia mentioned about the small number of patients this affects. It used to be pre-pandemic, every talk I went to on healthcare reform said that we needed to have a critical mass of 60 to 65% of folks in a payment model before you can actually change the way care is delivered. Post-pandemic, no one talks about that 60 to 65%, and I think that's because we realized that we can't get there, so people just stop talking about it. This is a Medicare model, so maybe 15% of patients. I agree, not having Medicare Advantage patients is huge, especially when Medicare Advantage patients, that's an increasing demographic in the state. So the number of straight Medicare folks is going to go down over time. Saying Medicaid has to align, it's not clear, is that just for quality measures, or is there enhanced payments with Medicare that'll be comparable to the Medicare, with Medicaid that will be comparable to the Medicare patients? Even when you combine Medicaid and Medicare, you're still at maybe 30% of patients for our practice. So if we don't get the commercials, Blue Cross and MVP in the room, it's impossible to make any sort of real transformation. And of course, Vermont, you can't talk about payment reform without acknowledging that there's a huge self-insured population that sort of the self-insureds play by their own rules, and so you can't loop them in anyhow. And I feel like that really needs to be addressed. We've said it for years, but there's got to be a way to address that, or this is not going to be successful. Finally, pediatrics. This is a Medicare-based model, and what happens with the peds folks who have very, very low Medicare numbers. In terms of the CPR program, I'll echo Alicia also that the CPR program has been fantastic certainly for my practice in Williston, for a number of our independent practices. It's a mixed bag. Some folks do not have the same positive outcomes with financially with the CPR practice as others. But we spent 5 years building on the system of capitated care, including adding positions around things like care coordination, stuff that's not reimbursed, but we could afford it through the capitated model. Now, all of a sudden, this is going to look very different if we go back to a fee-for-service model, at least until 2027, before they start maybe adding capitation back again. And again, the enhanced payments are only for those Medicare folks, so we lose the enhanced payments for the other folks in the system, and we only gain them for Medicare. There are a number of practices that feel that this would actually be a net loss to them in revenue at a time when we're trying to stabilize primary care. Again, the complexity of the model is tremendous. I think, Pat, every time I look at one of the presentations and we go through the slides, I again appreciate how many moving parts there are here. I feel like nobody really understands it. And when we talk to providers and groups, and even folks who are in the room about what is ahead, people, it's hard to even figure out what the questions are to ask to understand what's going on. While we all understand that the healthcare reform landscape is incredibly complex, there's no easy answers. If providers can't understand the model, they can't understand how it's going to affect their ability to remain viable. I will say that as evidenced today with the release of the anticipated insurance rate increases, we need to bring down the total cost of care. We need to bring down insurance premiums. And if independent and non-hospital players in the healthcare system start closing, it will have a direct negative impact on that cost of care. You've heard me say it before, I'll say it again, independent physicians and advanced practice practitioners like NPs and PAs provide high quality care at lower costs than other players in the system. The Ambulatory Surgery Center has consistently provided excellent outcomes and tremendous patient satisfaction at a lower cost than the hospital. Our lone non-hospital MRI here in South Burlington allows for high quality scans at about 25 to 50% the cost of a hospital-based scan, and access measured in days to weeks instead of weeks to months. Vermont's healthcare system can't afford to lose any of these providers. If the AHEAD model destabilizes these independent providers and causes them to go under, the total cost of care will go up, not down, and that is incredibly concerning. And finally, I'll just say the provider concern is predominantly about the many unknowns in moving forward with the system. And I appreciate, Pat, how much there is sort of stuff that we just can't know yet, or that CMS hasn't told us, or that's still in negotiation. But 5 years ago, when we had these discussions, before OneCare, when it was going to be Vermont Cares and it was going to be all payer, truly all payer across all entities, discussion was focused on defragmenting our healthcare system, aligning quality measures based on community needs, and simplified but appropriate reimbursements to support a primary care-based healthcare system. And that was the dream back then, and we all were excited sitting in the room about it. With this sort of AHEAD model, it seems like we're taking a step back to a more fragmented, more complex system, and it just doesn't seem like it's going to push Vermont in the direction that we need to be going. So I agree with Alicia. I don't know if there are other options available that are more broad, but I think Vermont can be a true leader. I'm not convinced, and I think a lot of providers I talk to are not convinced that this is the right avenue to lead. Thank you so much.
Thank you very much, Mr. Dooley. Susan Ridson.
Hi, thank
Hi.
you for the opportunity to speak today. I also just want to say thanks to everyone at AHS, Pat and Wendy and the other folks and all the Green Mountain Care Board members and staff and the healthcare advocate, hospital representatives, and basically everyone who has put so much time into understanding the AHEAD model. Just being able to listen to the discussions has been extremely helpful. So thank you for that. Rick and Dr. Jacobs did touch upon some of the strengths and weaknesses from the primary care perspective. I'll add that another strength that I think the AHEAD model does offer is the ability to continue to collaborate with CMMI and to a certain extent CMS by extension. I do think there's value in that, and keeping us in kind of the value-based program space, because I don't see that going away anytime soon as far as CMS is concerned. I also like the equity focus of the AHEAD model. And of course, the enhanced payments to primary care and Blueprint SASH funding and, the Medicare waiver access. That being said, we do have significant concerns, and I should have mentioned that I'm the executive director of Health First, and we represent 62, soon to be 61, unfortunately, primary care and specialty care practices located across Vermont. So some of the concerns we have about AHEAD and the AHEAD process, although Pat did speak to some of them today, and I appreciated that, Pat, thank you. But we haven't to date seen a detailed analysis of AHEAD versus the other alternative options. I think that's really important for us to have in order to evaluate whether we should move forward with AHEAD. I also don't see a clear glide path for practices to harmlessly transition them away from the all-payer model. Of course, that exists whether or not we have AHEAD, but I think that's something that our state really needs to focus some attention on soon, because I'm very worried about this transition destabilizing our already fragile primary care practices. I also foundationally do not see this model addressing affordability. For all practical purposes, we've been doing global budgets for some time now. We've been doing total cost of care, yet we all saw this week that we're looking at more increases in premiums, 9 to 19%. I just don't see AHEAD changing that dynamic. We need to use levers that will control the high hospital prices that are largely responsible for these rate increases, such as reference-based pricing. We also need to work to expand Vermont's network of lower cost sites of care. I don't know if folks are aware, but Vermont has one multi-specialty ambulatory surgery center. That's the fewest of any state in the nation. As Rick mentioned, we have one lone independent imaging center. Vermonters do not have choices to get lower cost care. We're very hospital centric, and we're paying high hospital prices for care that does not need to be delivered in a hospital. Don't get me wrong. We support hospitals. We believe we need a strong hospitals. We just don't believe that hospitals need to be providing all the care that they do. Let them focus on what they're good at, and let the community providers provide the other care at a lesser cost. We also don't believe that the model will improve access to care that we all know is an issue here. The model really seems to focus on decreasing utilization, which really isn't an issue here in Vermont. And, Pat did have a slide that talks about, the HEAD model is supportive of shifting care to primary care, and it may do that in some regards with the enhanced primary care payments. But also starting in year 4, the model, those enhanced payments are included in the total cost of care measure. And if we're trying to drive that down, that, could theoretically incentivize less investment in the primary care system. And really, this model just is not a system-wide model. You have the hospital part and you have the primary part, and we really need to shore up other parts of the system so that the hospitals, have the support they need to get people who need mental health support and home health out of the ED and into the community where they can get care. This model, I don't see doing that. This model is astonishingly complex and expensive to operationalize. I think of just what it's costing for all of us to be here today, and just the countless hours that we have all put in to try to understand this model, let alone operationalize it. I just feel so complex. It doesn't decrease administrative burden. It adds another layer of complexity, and it's this type of complexity that is, driving providers out of healthcare. Or it's driving them into the direct care model where they don't even accept insurance or participate in these models because it's just too much. They just want to take care of their patients. The other thing that it's helping to drive is just the private equity backed like management services organizations to help independent practices in particular, like deal with all these complexities. Is just too much. So this model, just contributes to that and distracts us from what really needs to be done. I don't see this model really helping to make clear the ongoing ambiguities, who's really in charge of improving Vermont's healthcare system. I'm just going to say it out loud. We seem to have this fight between AHS and the Green Mountain Care Board, and I don't see this helping that matter. We don't really know who's in charge. I also am concerned that the proposed AHEAD model governance seems to specifically include only one clinician. There is mention of provider organizations being included, but not necessarily clinicians other than the one that was specifically mentioned, unless I missed it somewhere. Rick talked about a number of the primary care issues. And so basically, in summary, we feel that this model is exceedingly complex and provides no clear evidence that it's going to address Vermont's most pressing problems of affordability and access to care. We believe that we should focus our attention on those things that we know need to be fixed, building a glide path for primary care to move away from the all-payer model, helping to doing more to recruit and retain primary care clinicians, strengthening the community-based services, and increasing access and utilization to lower cost sites of care, doing things like reforming the certificate of need laws that have basically resulted in Vermont having, almost no independent facilities, and most care being delivered in a hospital. So thank you for the opportunity.
Thank you very much, Ms. Fridson. Ms. Barnard, how are you?
Hi, good, thank you. Thanks for having all of us this
Yeah, good.
afternoon. Really appreciate the panel or the board hearing from this whole panel. I'm Jessa Barnard. I'm the executive director of the Vermont Medical Society. So we are a physician membership organization. We represent physicians of all specialties and practice settings, but I'm also speaking to some comments that I just submitted yesterday, and I think are now up on your board, off your board website under the public comment location on behalf of the Vermont Academy of Family Physicians and American Academy of Pediatrics as well. We work very closely with a number of specialty societies, but especially our partners in primary care at AAP and VTAFP. So these are on behalf of all of our organizations. And I will really try my best not to repeat. I so appreciate the folks who went before me, because I think you'll hear a lot of common themes. So I'll try to pull out a couple of points maybe that they didn't hit quite as much, or some things I really want to emphasize. One thing I really want to highlight, we appreciate so much the work that AHS has done so far to hear from providers and provider organizations. They really have done a lot of outreach. We participated in the primary care work group, which has had some very robust discussions. We know there are clinicians on the Global Budget Technical Advisory Group and the overall health reform group. So we just really want to advocate for keeping strong clinician and healthcare organization input into whatever model is moving forward. We think that's really key to anything working on the ground in our state. And to echo what Susan just said, making sure there is robust provider representation on the AHEAD model governance body. That's also something that jumped out at us as sort of peripheral to that group, where we think that should really be central to the AHEAD model governance body. I want to emphasize one thing. So I'll start with some primary care payments, this $17 per beneficiary per month payment that we've talked about, because one thing I want to point out is that $17 is an average, where CMMI is actually saying it will be a range from $15 to $21 perhaps. And that concerns us because part of the upward or downward adjustments to that payment is based on statewide performance, such as hospital participation goals and state Medicare fee-for-service growth targets, factors over which we're concerned primary care has little to absolutely no influence. So one thing we would like to ask for in negotiations with CMMI is a more predictable primary care payment, and also one that is actually under the influence of primary care practices. I will echo what you heard about the linking that 17 only to fee-for-service Medicare, as opposed to, so that could really impact pediatrics, especially, as well as practices that see more Medicare Advantage patients. So another request on that side is to ask for what AHS can potentially do on the Medicaid side. I think you heard this from Rick, or other ways we can make sure that practices of all types, all primary care practices, can benefit from payments to participate in this model. I also want to mention, and this, I know this is somewhat out of our state's control, but I just think it has to be called out because it impacts a lot of the provider organizations, is that while CMMI is dedicating additional resources to primary care through this model, on the other hand, CMS Medicare's fee-for-service fee schedule continues to decrease year over year. So this is Medicare's professional fee service fee schedule. So we're concerned, yes, it's great they're dedicating some more resources on here, but if the underlying fee-for-service fee schedule keeps being reduced, and in fact, in Vermont, it hits primary care doubly hard because Medicaid mirrors that fee schedule. So when that fee schedule is reduced, both our Medicare and Medicaid payments go down. And so that's something we think AHS and in negotiations, perhaps with CMMI, I don't know if there's a way to involve this, or just really encourage CMS and CMMI to be talking to each other about how can we make sure that all parts of our organization are supporting primary care in a coherent way, as opposed to one model working in one direction while the other side is actually undermining some of those goals. I think the one other piece that has not, it's been mentioned quite a bit, but I just want to pull out the piece about the disruptive change for primary care that this will lead to. We know there's going to be change. We know we can't have the all-payer model forever, but we think there needs to be adequate resources and support for primary care going through these changes, and it's not really clear to us where that will live. We have been lucky to have an ACO available that can take a phone call at any time and talk a practice through if they want to participate in their programs, if they want to participate in the CPR program. How does that compare to their current budget? How will this influence cash flow? What are the quality measures? What are the pros and cons of joining? The state application indicates some support by Blueprint for health staff and quality improvement facilitators. Our experience is those individuals are much more focused on clinical transformation as opposed to financial modeling, and really looking at a detailed fiscal impact analysis and support in a transition to a new model. So we would really request a plan for what entity would take the lead in those kinds of tasks, how that might need to be funded and supported. I want to make sure I hit my, we've heard about the CPR program quite a bit. We absolutely support the continuation of a capitated model for primary care. We understand the CMMI may or may not be able to start that right away. But again, we'd ask, is this a place where AHS and Medicaid could develop a capitated primary care program earlier to help fill some of that gap and bridge that transition? And we know that we've also heard or saw in the application looking at the Blueprint additional Blueprint PMPM payments to patient-centered medical homes to help complement additional payments to primary care or to increase investment in primary care. And we would support looking at that as a potential avenue. And one other, I also just want to mention data with this model and practices. A lot of this model, a concern takes a lot of the kind of filtering and interpreting of data, quality data, fiscal data, perhaps potentially from a state entity that providers participate in, the ACO, and puts that control in CMS's hands or CMMI's hands in terms of their attribution numbers, their quality numbers. So we are concerned about making sure practices have that data available to them. They can obtain and review for accuracy any Medicare patient data for attribution, quality, or performance measures. And I want to echo, I think what a few folks have said about reducing administrative burden. Another concern is losing the ACO waivers, the ACO prior authorization waivers. And so what can the state do? We've been working hard with a number of partners on this call around H766 around prior authorization on the commercial side, but are there ways that Medicaid and Medicare Advantage plans can also be looking at their prior authorization and administrative requirements? Can that be built in or negotiated with CMMI? So those are some pieces on the primary care payments. I want to mention the primary care spend target. We support having a primary care spend target and working towards an increased investment in primary care. We've been part of the work that DEVA and Green Mountain Care Board has been doing in this area for a number of years. However, we do think there are a lot of details still to work out, and we haven't gotten to sort of the granular understanding of what this might look like in Vermont. We again think that since the model governance body looks to have some role in informing primary care spend targets, that's another reason to need robust primary care participation in that group, and also some more clarity and detail between how this relates to our current regulatory structure. Sort of who's the lead on coming up with this target? How does it relate to existing negotiations with payers over contract terms and reaching those targets? How is it incorporated into the Green Mountain Care Board's current insurance and hospital rate regulation systems, and the role of the model governance body versus other entities in setting that target? So we would look forward to both participating in and knowing more about sort of the details on the primary care spend piece. We also support the importance of needing to build in hospital sustainability if we're moving towards a global budget, that needs to be a sufficient global budget to create predictability and sustainability for hospitals and hospital workforce. Again, we're a provider-based organization, and we've heard over and over about workforce pressures. We've had the wait time study, and we know that it's not just primary care there's lack of access, but also to certain specialty services. And if Vermont is not able to negotiate a sustainable global budget that captures savings and supports the ability to hire and retain both primary care and specialty clinicians, we're concerned it would hamstring efforts to have the workforce our state needs to prevent higher cost admissions, address these wait time issues, and more. So again, we appreciate all the work that's gone into this model and refer you to even lengthier written comments for more details on some of our recommendations. So thank you for hearing from us today.
Thank you. We received your written public comment, I think it was last night. Thank you very much for that. It's very thoughtful and helpful. So thanks for putting in the time to do that. Ms. Fox?
Good afternoon. Can you hear me? Yes. Okay. So
hi, how are you?
Thank you for inviting me today. And I agree with the presenters before me. Certainly some common themes in what we'll hear and what you'll hear around the complexity of this reform work, highlighting the critical importance in partnerships within our community partners, but also with our folks, you folks at the state level and federal partners. I'm not going to reiterate some of the comments that have been made. I'm going to focus on access and avoidable utilization and data. And the theme behind this is funding and thinking of ahead as a potential way to infuse more funds into our community. And collaboration, it needs to begin there, extremely important. We need a governance structure that supports collaboration, that understands the impacts on costs given access and gaps in accessibility across the care continuum. And our focus here as a healthcare system, as a hospital, is that we really want to provide the right care at the right time with the right providers. But unfortunately, this requires significant resources and infrastructure, many of which are not adequate in the state at this point. Requires full access to primary care, acute hospital care, mental health, home health, post-acute care, long-term care, and then an EMS service that transport patients to the right location. That structured and layered on with an engaged and connected care coordination team, vital to make sure that we're navigating these patients and providing them with information and coordination to seek care. Without this network, hospitals like Rutland are really going to face providing care that the AHEAD model would consider as being potentially avoidable. That's a significant concern for us. In fact, one of the greatest issues and drivers of potentially avoidable utilization is the lack of bed availability. And for those of you who have allowed me to speak before, this won't be new information, but certainly tertiary care facilities, long-term care facilities, residential treatment facilities, they all have collective access limits on bed availability or just requirements on admissions that delay and require that we keep patients here in our hospital. They also increase demand for emergency services. All of this prevents our patients from really receiving that timely care in the care setting that it should be delivered. At Rutland, on any given day, 10% of our inpatient volume is related to patients who do not require acute hospital care, but unfortunately, their reality is there's no place else for them to go to have their care needs met. This is not unique to Rutland. It's prevalent across the state. These patients tend to stay with us a very long time. We've got a patient here who's awaited placement for more than 600 days. So very, very acute issue here. And while considered potentially avoidable in the model and requirements for AHEAD, the fact of the matter is hospitals are serving as safety nets. And for us, we're providing essential care to these patients who don't have other options. And so we're very concerned in the AHEAD model about the definition and the requirements and related to the potentially avoidable utilization. We also believe, and through tracking and sharing information with the Green Mountain Care Board, that there are access issues in our state. And we're concerned that the AHEAD model does not provide a pathway for improved access to specialty care, hospital services, and primary care. And the reason for that is if we look at the model and we think of that model as looking back 3 years to set rates and set budgets with a time where we had excessive wait times and capacity limitations, we bake that issue into some of those funding. And so really wanting to think about and be creative and how we can meet our collective goals to increase access to care, to drive wait times down, and find a funding mechanism that's appropriate for those types of services. Which leads me to why Rutland Regional signed a letter of interest for this model, because we believe it is a tool that Vermont may have that would allow an increase in payments from the federal payers to address some of these infrastructure challenges and access challenges. If the state were selected to participate in the AHEAD model, we believe that in order to be successful in supporting access to care and beginning to address affordability issues, several AHEAD model requirements would need to be put in place. Front and center in that is increased Medicare funding. We think that is critical and is kind of a go, no-go situation for Vermont. It would allow healthcare affordability for Vermonters and provide some financial stability for our care providers, primary care, and hospitals throughout the state. And we believe we have an opportunity to go to a negotiating table that with some strength. If we look at AHEAD funding and acknowledge that Vermont is a low-cost Medicare healthcare provider and that we've consistently generated savings for the Medicare program. In fact, if we compare Vermont costs to other states and look at that median cost, Vermont's savings would be close to $300 million. And meaning that Vermont's hospitals are paid $300 million less for providing the same services. So if we were to move it forward with the AHEAD model, the model should provide mechanisms to make Vermont hospitals more financially stable, to allow for reinvestment in services and infrastructure that improve access to care. So not just hospital balance sheets and funding, but funding across the care continuum. And this all lies with increased, this negotiation for funding. A number of Vermont hospitals lose money annually in our Medicare population. And so this funding would be critical to ensure that long-term viability. But as importantly, additional Medicare funding would also support affordability concerns with our commercial insurers. And I think this is really important to try to connect the dots here, in that our commercial insurers would not be positioned to subsidize Medicare losses to the extent they do today if we can shore up Medicare funding. And this is extremely important so that we keep Vermonters in the state of Vermont to receive care, and they're not looking to go out of state. As we consider the healthcare ecosystem and consider the value of care provided across our care continuum, we need to be not short-sighted. Hospital, I'm going to advocate for hospital funding, but really important that we also think about our care partners in our community, primary care, designated agencies, substance use treatment services, home health providers, skilled nursing facilities, all important, again, to ensure that we don't have any of those gaps in care and patients get bottlenecked in receiving services in a care setting that may be inappropriate. And I'll just end with data. We see data, as we understand the AHEAD model, as being something at risk and a step back from where we are today. If we think about how we participate in the all-payer model and the data that we get from OneCare. As we understand it, it's fairly siloed, where participants would receive their own data from Medicare and not necessarily shared from a community perspective. That's problematic for a community like Rutland. We do not own primary care. And so if not for data sharing, we wouldn't have that opportunity to see a comprehensive data set that would allow us to identify opportunities to improve care delivery, to ensure that we really are committed to providing the right care in the right setting with the right provider. We do have this data opportunity and availability with our all-payer model, and that is something we feel very strongly that would need to continue if we were to move forward with the AHEAD model. As for Rutland, we have a long history of trying to work in partnership with reform efforts. We are really trying to understand how we can participate and move care forward in our community. We believe in transformation models, but we also know that they're extremely cumbersome, different, disruptive at times. But we're interested not only for increased funding, but we do believe there's an opportunity to improve equity, health equity, to support our infrastructure and those gaps, to increase that patient access to clinical services, financial stability for our hospitals, stimulating some growth and creation of access for post-acute care services and transportation. So while we remain optimistic here in Rutland that we can achieve these objectives if efficiently designed and negotiated within the AHEAD model, we also understand that the complexity of the payment reform, coupled with the need to negotiate for these payment terms and model requirements, could challenge Vermont and result in the need to reconsider moving forward. So just to summarize, really looking for AHEAD to infuse funding into the state to really take care of some of our infrastructure, our access issues, to respond to some of the concerns that we have in wait times and access to care for our community, and not wanting to take a step back in some of those payment reform activities that and care delivery reform activities we've participated in OneCare that have been really fueled by lots of good data to allow us to really pinpoint some opportunities and concerns in our community.
Thank you. Might be a good time to take 7-minute break. Why don't we come back at, or an 8-minute, we'll come back at 3:05, just take a short break. And I skipped Mr. Garland and Miss Molman. So when we come back, we'll go to Andrew Garland and Mary Kate, and then back on order. So we'll see you at 3:05. Thank you.
John, you applied to dental school this summer? Why?
It looks like everyone's back, so I'll turn it to. Try that again. Mr. Garland, I believe you were up next. Thanks for being here.
Thank you, and I'm just.
Why don't we? Do you have a phone on as well or something? We're going to skip Mr. Garland for now. No, it's Andrew. We'll see if we can get that to work out on the audio. Ms. Molman, are you ready to go? Do you want to share your thoughts?
Sure, happy to. First of all, Mary Kate Molman. I'm Director of Vermont Public Policy at Bi-State Primary Care Association. We support federally qualified health centers in both Vermont and New Hampshire. I obviously will be speaking towards the Vermont side. We also support Vermont's free and referral clinics and Northern New England Planned Parenthood. So first of all, thank you for hosting this gathering of important voices to hear. I appreciate the opportunity. A lot of what I have to say echoes a lot of what you've already heard, so I'll try to pick out those points that are most salient to our members. I also want to kind of echo a lot of what Pat said, in that there is a lot to learn still about this model and the specifics of how it will be implemented. And I think those specifics will really give us a better understanding of how this will impact our members, at least. So we're constantly trying to learn more and then give that feedback back to our members so that we can understand for them how it's going to impact. But in general, right now, FQHCs are really struggling. Funding streams are declining or flatlined, and costs are increasing. Many health centers are looking at significant operational losses, some as high as in the 7 digits. And in these situations, the first services that go are the ones that we as a state keep pointing to as key to slowing the growth of healthcare costs. For example, we often point to pharmacy as one of the biggest contributor to high healthcare costs. And but programs that could mitigate. Oh.
I think is Andrew Garland.
Sorry, I'm hearing some echo. Someone. Okay. Programs that could mitigate the need for pharmaceutical approaches. These are programs that promote nutrition, physical activity or mobility, or social support networks. These are cut when budgets get lean. Also, staff and services get cut, and this affects access and especially equity to access. Those who historically or currently have the highest access challenges will be probably the first affected as you start to cut back these services when these budgets are so lean. So the need to invest and support primary care is really real, and especially in the health center FQHC side. So we really appreciate the AHEAD's model focus on primary care and elevating it as an area for reform. That the focus on the integrated multidiscipline care, such as integration of mental health, substance use disorder treatment, those are really at the heart of the FQHC model. And we really appreciate that that CMMI has pointed to that as critical to this next phase in healthcare reform. But the details really matter. So the 17 PMPM, we've seen AHS put out some numbers, and it looks like, at least for the Medicare population, that could be a net gain, but we still need to understand more of those numbers and also what it looks like in the context of the other payers. So again, like how would, as more Vermonters shift to MA plans, how might that affect the net funding that goes to our health centers? As we transition away from the all-payer model, what happens to the ACO payments, and how does that affect the net revenue for our members? We don't want to make the situation worse. It's already really slim. So we really need to understand those numbers. And then again, sort of understanding that participation from other payers. I think Vermont Medicaid, I want to applaud them for being as really as cutting edge as they have been with their next generation ACO approach. The fact that they have gone out there and it's an unreconciled population-based payment, that's what we need more of. But I would also want to understand more about how that funding has trickled down and impacted primary care, not just within the hospitals, but also across the system. We've talked a lot about how healthcare reform really needs to pivot and build off of primary care. It's not just primary care, I will say other aspects of the healthcare, but there has been a lot of focus on primary care. And I don't think we've seen the investments to date to really match that rhetoric. But I do also, just to be fair, I want to call out and I want to express my appreciation to DVHA that they are working with each of our health centers to update each of the health centers' federally required minimum payments so that it does reflect their current scope of services and their current population served. And I also want to say I was pleased to see that in the state's AHEAD model application, they mentioned the alternative payment methodology report that was submitted to the legislature last fall. There was a lot of work that went into developing that payment model, and it's a model that really does a good job of reflecting the reflecting the cost of providing comprehensive integrated care that really is at the heart of what FQHCs do. And so we, Bi-State and our members, really hope that the state is serious about considering implementing that payment model as part of the broader multi-payer approach in the AHEAD model and the shift to value-based care, assuming this is the direction the state's heading in. Also, learning more about the commercial payers' role. Payers don't, or they shouldn't, treat patients differently based on their coverage. And so we like having different siloed approaches for care management, care coordination, quality reporting is a real burden on providers and does a disservice to the patients to have that kind of segmented care structure within a single organization. So having more of the payers at the table and alignment across those payers in terms of the care coordination, quality, care management, support services, that's really what serves the patient. So we would want to see some more information on how those pieces are going to come together. And I'm sure you've heard this word a couple times already, but administrative burden, this is another massive stress on our primary care providers and at the health centers. And it's hurting our workforce, and we need a workforce to provide this essential care to Vermonters. And when you have workforce that's spending too much time on paperwork, when practices are spending resources on administration, not care, when clinically necessary care is not paid for, then staff leave, services are cut, access is reduced, and this primarily hurts Vermonters. So I think I'd love to see more about how this model can potentially alleviate some of these weights on our primary care providers. I think learning in summary, just learning more about what the specifics are about the implementation is critical, and the global budgets. And I know these are coming, but it's something that we're really watching carefully. And the AHEAD model and the global budgets, that the success of both of those will really require not just a robust primary care system, but also the other parts of the healthcare system, which really helps making sure patients are getting the right care in the right place at an appropriate level of care, at an appropriate timing for that care, like making sure you get that primary preventive care as opposed to that emergency or acute care because you waited too long. I also want that there's a lot of this support will really come down to funding, but I also want to call out the funding alone is not the only issue. It's not going to solve everything. If you just throw a lot of money at the problem, I'm not sure we're going to fix the underlying problems. So really having some strong leadership and a clear vision about how all of these pieces are going to fit together People have mentioned the complexity of this, and Pat, I do not envy the jigsaw puzzle, the 3D jigsaw puzzle with no cover or picture to draw from that you're trying to do. Like I just want to appreciate that, but there needs to be a real strong leadership in helping make it clear how those pieces fit together and how the different partners in the system can step up and work together. And I think you heard echoes of that in people's comments on the governance and the complexity. So I think that's where I'll leave it. And just again, it's all reminding everyone that the heart of this is it's the Vermonter. It's making sure they're getting the care in the right place at the right time, in the right setting. So again, thank you.
Thank you very much. Mr. Curran, you want to try your audio again?
Yeah, hopefully this is better. How am I doing? All right.
Sounds great.
What I was
Thanks.
saying was, I hope I'm not the one creating the echo, ironically. Okay, so I've been surgically going through my notes here, trying to cut out everything that everybody's already said. And I will say, not only do I think almost every single point I wanted to make has already been made, but I've written down a ton of really thoughtful comments from everyone who has spoken before me. I think the dialogue is right on. So I'll try to just give you a few thoughts that bring the perspective of Vermont's local non-for-profit health plan to the picture, very similarly aligned with what we've heard. We hear from our members every day. They need us to find ways to help move this healthcare system forward. We're spending too much money and we're not providing for everybody's needs. So I would frame, I think Blue Cross would frame our primary challenges as affordability and access. I think it's so important that we're having this discussion, that we're evaluating this model, that we evaluate every opportunity that comes in front of us. But I hope that we will make our decision on whether or not to proceed here based on fact and not be afraid to say no to this model if it does not address our needs and move on to the next best alternatives, which I'm sure there are many. And I want to thank you, Pat, for mentioning the portfolio approach, because we strongly believe that there is not a single magic bullet here that is going to move our healthcare system where it needs to go. Right? We have dozens of major challenges, and there is no model comprehensive enough to take them all on at once. So really important comment. And the other thing I wanted to say just at the outset is that we're probably not going to create the value we need for Vermont if we let CMMI lead us forward on this. We need our Vermont leadership to step forward and drive us forward to where we need to go. I said to a colleague that, you know, CMMI will boil our frog if we let them. And I think it's important for us to recognize, as Judy said so eloquently, Medicare is not putting a lot on the table for us here. And they have created a massive cost shift in our state that is making commercial care, or commercial health insurance almost unaffordable at this point, or unobtainable. It's certainly unaffordable. So I think we're very right to ask, does this model bring enough resources from CMS into Vermont? And if not, what are other ways we could pursue those resources? There are certainly other avenues that we could think about. So I talked just a little bit about complexity. Blue Cross is very supportive of any efforts that simplify the system, but I'll just make the point that if we're only sort of simplifying, as a lot of people have said already on this meeting, we're probably making things more complicated. And I think this is likely to be one of those cases. And I'll just offer a few points that I think support this thinking. Global risk sharing models, for example, they establishing and tending to the methodology that goes with the global risk share takes an unbelievable amount of energy and effort. And it's not one and done, right? And frankly, from the Blue Cross perspective, we have been negotiating, or we were negotiating with OneCare Vermont to find the right methodology from about 2 years before we started that program to the day we said Blue Cross won't be able to continue supporting this program right now. A constant negotiation about methodology. That negotiation distracts us, right? It adds cost, it complicates our alignment, makes it hard to communicate up and down. And it most importantly, it pulls our leaders away from focusing on the problems or the opportunities to make meaningful change. And the more global the risk, the less room there is for mistakes. And that's the real point, right? When a Blue Cross or a major hospital is sitting down to look at a global budget methodology or a global risk methodology, there is no room for error in this system, right? And we're talking about a methodology that may come with dozens of factors or adjustments, right, to consider. There is no room for error, not by Blue Cross, not on behalf of our members, not by any of our hospital partners. No one could afford to lose in a model like this because we didn't get the methodology right, which means we have an almost infinite regress of arguing about the methodology. And it's fear-based, right? It doesn't empower us. It makes us afraid. As many people have said, these CMMI models, and I've participated in a few in Vermont and outside of Vermont, they come with a huge additional administrative layer. And again, this distracts us. We just came out of a legislative session where administrative burden was one of the themes of many of the conversations that I was a part of. Do our Vermont providers have the capacity to take on more administrative burden? And I would just remind everybody that it's not only providers who get pulled into this. I see people sometimes offering the OneCare cumulative administrative budget as a good placeholder for what we've spent on the all-payer model, but state agencies, designated agencies, health plans, many of the people on this call, I mean, there's so much administrative work behind making these work, which doesn't mean that we shouldn't do them. It just means that we need to be really confident that the evidence says we're going to create the value we need, and that value outweighs the administrative work we're asking everybody to take on. So for evidence, I really have just one question here. Do we feel like we have enough evidence to step into a 10-year all-payer model that doesn't seem to come with a lot of money or a lot of flexibility? And I understand that the Medicare waiver is very valuable, but there's not a lot more that Medicare is putting on the table. And it's not clear that this model that they're offering goes at what Vermont needs. As I said, I think we're looking primarily from our perspective at affordability and an access. But when I look at this model from a high level, and I know you're working really hard on this, Pat, I appreciate it. I see a model that seems to be trying to solve for overutilization. That seems to be the construct here. And I'm not sure any of us would raise our hand and say, yeah, we think overutilization is the big problem that we're struggling with here in Vermont. I don't think that's it. And just another thing to say about CMMI models, like this one, they're not usually tested before we jump into them, right? There's a lot of concept, a lot of high concept thinking, and I think that thinking is very energizing and exciting. There's a lot of information there. We should take it and make the most of it, but we should acknowledge that this has not been tested. And our market is a very irregular market to try to test something like this that doesn't seem to be designed to do what we need to do. Just a few quick points about structure of this model. What incentives are we thinking we're bringing to the table here? With the built-in inflators, the inevitable off-ramps that we're going to have to build into this global budget methodology, I'm not seeing how we drive forward affordability and access. That those things don't really seem to be what this model is about. And certainly it doesn't provoke us to have the hard conversations that I think we all know we need to really have. We've heard many of them alluded to in this session already. But are we really engineering the healthcare system that Vermont needs? Or is this just another program that will probably accomplish something, but will also take us away from driving toward the most important questions about how we manage all of these resources so that the people who need them can actually afford them. A couple of other structural thoughts that occurred to me. These are pretty small potatoes, but I think they're worth mentioning. Most of our hospitals and independent practices are multi-state operations. Maybe there's a few right down the middle who don't get anybody from New York, Massachusetts, or New Hampshire, but I think most of our practices are multi-state operations. And I just wonder if a Vermont-only solution is enough. And again, going back to that point, if we're only sort of simplifying, are we actually simplifying, or are we just adding more complexity? I'll just also mention that people may not realize this, but there's a lot of people who access our healthcare system that do not live and work in Vermont. Many of them are Vermonters on paper, many of them are part-time Vermonters, and many of them are people who just choose to spend time here, but they're not necessarily covered here or participating in our system fully. So there's just another layer of complexity that a Vermont-only solution brings that might actually make this more complex and not more simple, as I think we would all like it to be. Another question, do we see adequate focus on mental health, substance abuse disorder, access to long-term care beds, access to primary care? You know, when I talk to clinicians or clinical leaders, these are the themes that I'm hearing over and over and over again, right? This model doesn't seem to be designed to solve those challenges. I think we could point it at some of them, and Pat's really creative, and I know we'll keep working and thinking about ways to bring those other considerations to the table. But fundamentally, that's not what this model is about. PCP ahead, my questions there are very similar. I love what it represents on paper. We absolutely need to invest more in this primary care system. I'm not sure that this model does much of that. It's not that easy to see, and I empathize with the concerns that many of the providers who've spoken earlier on the call laid out in front of us. And I'm also afraid that if we do find a way to invest more in primary care in this model, we're going to turn right around and ask our consumers to fund that, and I don't think they can afford it. I know they can't afford it. We have to find other ways to solve these challenges than keep going back to the commercial market and saying pay more, pay more, pay more. That capacity is tapped out. So to me, that means we have to look to the hospital side of the line and ask ourselves, can we find a way to bring dollars from the hospital spend, which data tells us is probably too high, to the primary care spend, which data tells us is probably too low. Again, the model doesn't really do that for us. And I guess maybe my more important point is I don't know that we need the model to do that ourselves. I don't see much besides $8-10 million from Medicare that this model brings to Vermont that the board could not do on its own, or that this group couldn't do in a way that serves our needs a lot better, I think, than a CMMI program would. So I would ask again: is there enough investment in our community for the effort here, or could we find other ways to accomplish some of these things? Final thought: we have to know how we're going to measure success, and I mean crystal clear, because if we're not arguing with OneCare about how we should set the methodology, and I say this kindly to my OneCare friends, we're arguing about whether or not we accomplish something. It is really hard to know, right? When you embark on these broad-based social engineering projects with so many variables, did we move the needle? Did we do anything here? And it creates a lot of bad energy and distraction for all of us as we try to focus on real change. So if we do move forward with this model or something like it, I encourage us to make sure we know how we're going to measure and to be dynamic. Locked into something for 10 years that doesn't offer us the ability to sense and respond to what's going on the ground is not likely to serve us very well. We need to be able to understand where we're being successful, where we're falling behind, and make changes in real time. Locking ourselves in for 5 or 7 or 8 or 10 years, that's a hard course to see really delivering value for us. So thanks very much. That's really all I had to say. And like Susan Ridson, I'm so appreciative for this dialogue. I don't think this happens everywhere. So thank you everybody for making this a reality.
Well, thank you for saying that. And we're extremely appreciative of everyone taking the time to do this for us to help us understand. So thank you again, everyone. John Aislinn.
Hi, I'm John Aislinn. I'm the COO and CFO for Primary Care Partners. We're the largest group of independent primary care practitioners in the state. We're a group, not an association. So we have offices. We have 10 medical offices in Vermont, ranging from Bennington and Brattleboro right up to Newport and Enosburg Falls. So we're pretty spread over. About 50 practitioners serving about 35,000 patients in Vermont. I guess I'm glad to know that when I read the application, it just seemed like I didn't get a clear understanding where we're heading. Apparently, I'm not alone. So there are so many questions out there, and but in saying that, I just want to express my appreciation for AHS and their hard work and putting the application together. I can see how incredible it must have been to have submitted this, and I thank Pat for your comment earlier where you said the next step is getting understanding so we can see the value. And it seems that getting that understanding is trying to grasp all these questions and bring that information back. And it seems it requires some ongoing negotiation post-election. But I thought, well, you know, rather than trying to go through all the questions, I just want, maybe from my perspective, I just want to touch a little more on the CPR aspect of it, not that it's part of AHEAD. That, if anything, for us, that's probably the most concerning thing, is that we feel like the CPR program, which we've been a participant in for 7 years, we feel like there's a dismantling of it. And I could see you're not going to complain about it leaving, and you could just say, well, you know, staying the course really isn't the option. But I can't tell you how much, I tried to tell you how much CPR has been of value to our group, and I know we're not alone. It has brought stability to primary care right from inception in 2018, and certainly helped through COVID. But it was more than stability for our independent practices. It offered us an opportunity to collaborate with the hospitals, to be sitting at the same table and having discussions about healthcare delivery in the state. I can't imagine any other forum that had that kind of a collaborative opportunity. And I fear the loss of that collaborative opportunity as we transition to this new Medicare-driven, CMS-driven, whatever model. But CPR went even beyond that in delivering greater investments to the primary care practices to really provide enhanced mental health funding beyond Blueprint, to be providing care innovation opportunities like remote patient monitoring, to be just giving us the room to breathe, to explore other opportunities to maybe develop, we did develop better patient management tools that we could look at the patients that have the challenges, not the numbers. And it was all done by this investment that came through the OneCare CPR program. And it seems that basically with AHEAD that the Medicare program is going to end, and I don't know what it really means for the Medicaid program. Can that possibly survive? But it gives you a lot of questions out of there, right? And the big question is, if CPR is going away, what is the crosswalk to what's happening? Because are we losing funding now in the new Medicare program? If it means losing funding, it means going back to all of these opportunities and these things that we've been doing to enhance patient care and figuring out how to pull back. You know, I mean, one of the biggest fears we always have when new money is pushed to develop programs is that it won't last. And that suddenly we're left with a structure that now we've got to own and figure out how to fund or dissolve. And you know, we've every opportunity you've heard us advocate. I'm saying myself, Dr. Sackhoun is the chair of our group. We've advocated for CPR. We've seen the value for the group. We've done op-eds. We've done all we can to try to be sure that CPR just continues. And it's disheartening to be in a situation where we feel we may be losing grip on it. And in mind, I say that, but I look at the primary care ahead goals, and they talk about, oh, it's designed to increase the investment in primary care. It's aligning Medicare with state-led Medicaid efforts, increasing overall capacity for care coordination, improving quality, offering whole person-centered care, minimizing provider burden. And you go back, well, minimizing provider burden, what is MIPS? Right, and so we're seeing the words, but I don't know where we're heading. And I through the application again, I thank AHS. They're talking about building upon what's here in Vermont, and it's great. I don't know what we'll be able to salvage. I don't know whether what could be left with CPR. I don't know what OneCare is going to do. Will there be, there's an organization that has been beneficial for CPR, and I just don't know what the long-term plan is. And AHS even acknowledges that throughout the application, right? There's big questions about what OneCare's role is going to be. So I don't know what, right now, I'm glad to hear that everybody else is struggling as much as we are, because I have no idea what Primary Health Partners is going to do. I fear that maybe this is going to be the only option, and we don't have an alternative, and it's probably making the best to go with this. But I'm always obviously anxious to see what other opportunities. Is OneCare going to come up with something? There's talk about them doing maybe an MSSP model. I don't know, right? There's discussion that was also in the application. So I guess I should wrap up that basically, it's too bad that despite all that we've said to advocate for CPR and how far it has taken us, that we find ourselves like we're losing grip on it and falling back to something else. And I can only hope that somehow it turns out better. But right now, I fear that we got to start thinking about changing what we're doing and the programs that we started, and how do we adjust for this? How do we find the collaboration or do we lose all the collaboration? We go back to our silos of just us. There's so much fear, and I'm hoping, go back to Pat, your question, maybe some of this will get resolved when you get more answers from CMS, and we could think this through and truly see the value. Put it there.
Thank you very much, Mr. Aislinn. Mr. Wooden?
Yep. Is that working?
It is, yeah, we can hear you and see you.
Great. Kind of exhausted. This is just a lot to take in. I can't believe you guys do this all the time with this much input. I appreciate all that you do, but it's a lot. And I only now and then tip my toe in the water. So thanks for what you do. It's a lot to figure this out. I really appreciate everybody around the table, every organization, and everybody participating. We're all Vermonters trying to figure out how to make the system better. I'm always reminded that in the three-legged stool, because I like to keep things simple, it's most about cost of care. I know access is right behind and quality, but we tend to just talk about money a lot, which is kind of a disappointment when we also should be looking at quality as well as access. I want to sort of broadly say that in many cases, we have to be leaders, and there's, I don't know, thousands of books each year that get put out by leaders. I've never found the book yet, maybe somebody knows, the book on how to be a really good follower. Those books don't get written, right? How do you become a good follower? So Vermont's trying to be a leader. Once again, we represent a very small percentage of the population. It's actually about 0.2%. It's not even 1%. And to me, it's hard to understand how ourselves in Maryland, we've been through this road before with the ACO model. We've talked about that for a long time. It's hard for me to understand how, but we're going to sort of, once again, try to take the leadership role. I think in the ACO model that we looked at, and I know the comments were very helpful, how do we measure it? What's the success? What are the failures? I fear that most of this discussion is always the pros on doing this. We got everybody all salesed up, let's do it. And we talk about the pros. We never talk about what are the cons, what are the pitfalls? What are our top 10 concerns? What did we learn about the previous healthcare reform. That makes me scared. That makes me worried. I can't run this organization at Copley. I work at Copley. I couldn't run Copley that way. Most businesses can't run that way, but I sort of feel like we are just going to the next answer as opposed to thoughtfully just thinking about what should we do and what should we hold off on. So the pressure to make a decision also is concerning to me when all of a sudden we sort of feel like we've got to make a decision, and the commitment being so many years. And when we say there's a chance to get out of this, the chances get significantly diminished the more time you spend into it. I mean, that's actually correlated. The more time you spend with somebody or an issue, I mean, there's a lot of psychology around that the higher the chances you're going to be part of the team, you're going to say yes. So we're spending a lot of time on this. We got a lot of data, a lot of charts. I just want to express my concern that we don't know enough about it. Half a dozen or more people said they don't fully understand it. And these are people in the healthcare field. We're not talking about just somebody on the street. This is very confusing. And I do love the KISS principle with your messaging. And we're having a hard time messaging this to each other to really understand what are the levers, what are the positives, what are the negatives. So I just have a lot of red flags, and I don't want to see us waste time trying to lead when in fact we might want to just be a great follower and stick to the knitting, as I say, good old Vermont term, stick to the knitting of just making continuous improvements in the cost of care in Vermont amongst all the providers, as well as the access issues and some eye on quality. But there's a lot we could do right now without like signing up for a multi-year commitment. So I don't mean to be just a naysayer and, you know, throw water on the campfire. I just want us to be realistic about this. And then the politics in America, I don't know if anybody is aware, I consider this year probably going to be the most interesting years I will ever remember, because by the end of this year, we're going to vote and we're going to have a existing president or a new president, and that can throw everything out the window. Do we not know that? We know that when we did the last presidential change, stuff can be just changed like that. And so if we sign up for a model not knowing the politics, and nobody knows the politics at this point, I just think that's a risk. Lastly, Copley is a critical access hospital. There's 8 of them in the state. We get some additional reimbursement for some cost through Medicare because of our small size and the recognition that you need diversity of healthcare settings. There's about 1,300 of them in the country, maybe 1,400. So for us, this doesn't look that appealing because it introduces a lot of risk. It was same was true for the ACO model. So even if we go down this road, it's hard to sort of take the current, but we're very small. We're only 2 or 3% of the entire state's hospital budgets, but it's hard for us to sort of see that for us it would be valuable. Lastly, I'm going to just make a comment about grants. I think it's easy to chase grant money. I think it's easy to not figure out what you're going to do after the money runs out. And grant money can sometimes take us away from actually making good objective progress. Grant money tends to focus people as opposed to having them focus creatively as to how best to fix the system or save cost or improve efficiency or coordination. So I got a great article, 7 costs on the money chase, how focus on funding influences progress. And that's not in a good way. So we just got to be careful, because if we're chasing and lauding the tail, in the end, it just doesn't sort of make sense, even though it's money, and it sounds like a lot of money, but relative to our, just the hospital side, it's $3.5 billion, never mind all the other profit, nonprofit, even Dartmouth, which we don't consider. They do a great job, but they're not part of our system, unfortunately. So I just have a lot of red flags. So I apologize. I'm just sharing those. I appreciate everybody's work. I don't have the magic answer. I know less is more, and keep it simple. We might actually be able to get on board, but it feels like it's beyond rocket science, some of these constructs. Thank you for listening.
Thank you, Mr. Wooden. Mr. Benson, Rick Benson.
Good afternoon. I'm Rick Vincent. I'm the CFO of the UVM Health Network. lived in Vermont my whole life, grew up in a little town in the Northeast Kingdom. So obviously the discussion today is very important to me, not only in my day role, but I have many family members that that utilize healthcare throughout Vermont. So thank you for the opportunity to share some comments today. I also want to thank everybody that's gone before me, and it looks like a few people that are going to come after me for the words and the feelings that they've shared, especially those that provide direct patient care. The passion and the energy that John just shared in his comments, wherever we land in this journey, we want to make sure that the model appropriately values the expertise and the effort that our providers are putting into taking care of patients, and that we don't have a model that somehow negatively impacts access to that excellent care that our providers are providing. As the board knows, as Judy shared for Rutland, the UVM Health Network also did submit a non-binding letter of interest for the state's AHEAD application. We did this because we do think that there's an opportunity with AHEAD to at least explore, as it potentially aligns with the interests that we have in shifting payment and delivery system in Vermont to be more grounded in value-based care. It highlights the potential for improving funds flow to primary care, providing stability for hospital levels of care, and supporting the beneficiary connections to community resources. So all of these things that have been highlighted in the CMI AHEAD model, we certainly value. Just in the interest of time, I'll just highlight a few. As many people have said, some of my comments are going to be repetitive, so I'm just going to maybe zero in on a little bit more of the kind of the technical things that we will be looking for in terms of the AHEAD model. We did submit for those of you who are not aware, we did submit a letter to Secretary Samuelson and her team on areas that we flagged as important as the negotiations with CMMI are ongoing. So there's 3 areas. One was the administration of the model. 2 was financial stability. And then the 3rd, which I think you've heard multiple times, was data and reporting. In terms of administration of the model, we want to make sure that we have a transparent, predictable model that's grounded in actuarially derived to risk-adjusted per capita cost targets. That's important that the model include that, and that we need a representative body of clinical, financial experts, Green Mountain Care Board representation to advise the model. We will make sure we have plenty of expertise and diverse backgrounds in terms of the team that is advising this model. In terms of financial stability, as everybody has, or many people have highlighted already, it does highlight and actually quotes that one of the goals is to provide financial stability for hospitals. We view that as incredibly important. I think Judy touched on this a little bit. I think actually Andrew might have touched on this as well. Vermont has long been one of the lowest cost Medicare states in the country. So it'll be important for stability that we're rewarded and not penalized for that low cost delivery and high quality of healthcare. That will help with the cost shift and take some pressure off commercial rates. So we 100% support the proposal that Pat and her team have put forward in terms of increasing the baseline budgets by 10% in the first year of the model. Next, we need to make sure that the model is responsive to the growing and aging demographics that we have in the state. So we're going to need, from our perspective, a Vermont-specific trend, not a regional growth trend. We need to account for the limited access that we're currently experiencing in our state and incorporate annual updates reflecting where services are being provided. And then lastly, as has been mentioned multiple times, we need to recognize mental health, substance use disorder, post-acute systems are collapsing under the weight of historic underfunding. We need those systems to deliver the care that Vermonters deserve, and this model needs to be responsive to those systems of care. And as I think everybody knows, those systems of care operate outside the four walls of our hospitals, so we need to make sure in this model that that those are addressed. The last area, data and reporting, to be effective, we do need ready access to timely data. We need regular all claims payer feeds that go directly to the participating providers. And then we do need, as we have in the ACO, the waivers necessary to actually act upon that data to improve the health of our patients. And this, again, has been said multiple times. We need to make sure that the negotiated model does not add to the administrative burdens, either through quality reporting or the regulatory requirements of the model. So everything I've shared so far is based on our current understanding of the model, and thank you to Pat and her team who have been key to kind of highlighting what they know as well in terms of what the model is telling us today. When we do get more information and we see the final model, we will review that as a health network through the lens of our patients, our ratepayers, and our communities. Our analysis will certainly focus on whether the underfunding of federal and state payers will continue to put pressure on our ratepayers and potentially access to care. And then finally, we look forward to continuing to work with the state to understand the details of the model as they continue to roll out and the negotiations continue with CMMI. So thank you for the opportunity to share our comments.
Thank you. Thank you for being here. Ms. Green, Devin Green.
Thanks, Chair Foster. Quick question. Are we ending at 4 or are we going to roll over?
We can roll over.
Okay, great. So thank you for having me here today. My name is Devin Green. I'm with the Vermont Association of Hospitals and Health Systems. We represent Vermont's hospitals, all of which are nonprofit, and want to say that we really appreciate the board seeking our input. We know AHS and the Green Mountain Care Board have met with providers a number of times, and we appreciate that process. I would say overall for the AHEAD model, there is a lot of concern about the disruption that it could cause, and I agree that we have no room for error. At the same time, it also feels like we can't afford to not explore all of our options. And so I do think it's worth exploring all of our options as we have them before us, whether it's the AHEAD model or fee-for-service or Medicare Shared Savings Program or some combination thereof. I'm going to speak a little bit to the Vermont-specific Medicare global payment methodology and then lead into other aspects of the AHEAD model, and I'll try to make it brief. I will say that I've agreed with a lot of the concepts that have been laid out here today. So in terms of the Vermont-specific Medicare global payment methodology, we do appreciate that, first of all, that we're taking up this option and we're not just doing the Medicare methodology wholesale. So we appreciate that we're trying to do things a little bit differently for Vermont. We support the flexibility in setting the base and having an alternative option and taking the higher of the two in terms of setting the base for hospitals. We also think it's really important that we get the Medicare total cost of care right. We have done a lot in the state in terms of healthcare reform. We've saved Medicare a lot of money, and we think it's important that that be reflected in the total cost of care to provide room for Vermont to be innovative and improve access going forward. In terms of the adjustments under the global payment methodology, we think that the Vermont Delivery Reform Investment Adjustment is crucial, and we see a lot of potential opportunity here. So we think within that there's within either this Vermont delivery reform adjustment or setting the base, we think there's a lot of opportunity to fulfill the Act 167 commitment to have value-based payments take into account the sustainability of Vermont's hospitals. So setting up hospitals for sustainability so that they can provide that care. We don't want to jeopardize access by locking in negative operating margins and making hospitals unsustainable. We think there is an opportunity to impact commercial rates. Again, if, as Ms. Fox said, we set ourselves up to the 50th percentile of where Medicare is, that will have an impact on rates. And then there's also a separate opportunity for health system transformation. So these are all things that we want to pursue. We know healthcare system transformation is very difficult to pursue without Medicare involved. And so that's why we are taking an opportunity to look at the AHEAD model. In terms of the inflation factor, we hope that the inflation factor could reflect the reality of what's happening to Vermont on the ground. We know that workforce is a very big piece of Vermont, and that our aging workforce plays into it, and that we're more negatively impacted than other areas of the country. So we would hope that that would be taken into account as we look at inflation. Workforce is a huge contributor there. I think it's also worth taking into account in all of these adjustments, technology and innovation. So I want to make sure either in the inflation piece or elsewhere, we take into account the idea that as healthcare improves, that does tend to increase costs, but we probably want access to greater innovation and technology for Vermonters. And so how are we going to address this in this model as well? And then in terms of the performance adjustments and the potential avoidable utilization, Vermont's median rate is lower than the national average, or Vermont is lower than the national average when it comes to the median rate. And so we do think that should be taken into account. I want to really stress what Judy Fox said and others said about how other parts of the system impact hospitals in terms of long-term care, mental health. Transportation is a huge impact to hospitals and avoidable utilization and costs. And so we would want that taken into account with this model as well. So that's what I have on the model piece. In terms of on the global budget piece, in terms of the model itself, I agree 100% that primary care can't lose its gains at this point. We've done so much to in the primary care world, and it would be terrible to lose what we've done there in terms of trying to stabilize primary care and improve it. I want to again mention critical access hospitals and take into account that critical access hospitals do not have economy of scale. They've really been set up to address access in areas, and Vermont has a lot of areas of need, geographic areas of need for access. And so when we look at our critical access hospitals and how this model impacts them, we do need to take that into account. And then in terms of data, again, we share the concern about data and how we share it and how we work with our community partners in terms of getting it so that we can make improvements in healthcare. And so we would want to see more information about that. With governance and regulation, I think we do need more information in this area and how it will work. So Act 167 includes that the proposal for value-based care and global budget payments would ensure reasonable and adequate rates as well as a predictable schedule for updates. And I think that predictability is really important. Delivery system changes are not going to happen if hospitals are unsure of what their budgets are going to be. We can't invest in the future. We can't invest in community providers. We can't invest long-term if it's unsure what our budgets are going to be each year. So we are really looking at setting up a regulatory structure that is based in predictability and would allow for these things to happen. We also really encourage all areas of expertise to participate in both the governance structure and the regulatory process. I'll just note that Pennsylvania has payer and provider representation on its board. Maryland has payer representation, a hospital CEO, and a vice president of provider and payment transformation that comes from Johns Hopkins Health System on its board. And so we would like to keep the communication open between the financial and administrative expertise, as well as the provider expertise in setting up these global hospital budgets, because as we mentioned, there's no room for error, and we need to make sure that we're all aligned when it comes to these global hospital budgets. So moving forward, we really appreciate the Green Mountain Care Board and AHS's transparency in this process.